This is a case that I'm demonstrating some techniques that I use to repair a recurrent large macular hole. The patient is monocular. Unfortunately, the macular hole didn't close after the first vitrectomy. This is a second surgery. You can see that I'm creating a subretinal saline blab. You can see there's some air in the blab. So the idea is try to do multiple injections to detach the macular area. So the second blab is inferior. However, you can't really control the direction of the blab. So I decided to do another one temporal to the macular hole. You can see there is a shallow subretinal blab that is actually able to expand across the macular hole area. So now I'm using a flex loop, try to gently massage the surface of the retina to give the maximum amount of flexibility. Also massage the edge of the macular hole. If you look carefully, you can see the previous IOM peel was actually pretty broad. So now I'm trying to use the flex loop to create another IOM flap. So the trick here is that you pre-place a drop of viscoelastic in the hole. That will be very easy to hold the flap. Otherwise, it will be very easy to lose the flap. So now under the macular lens high magnification, you can see the flap was created and also moved to the macular hole. So I use the sharp skin forceps to gently push the flap into the hole. Actually, I realized that with the subretinal sealing, to detach the retina, it's just very easy to fit the flap into the macular hole. Of course, you have to be really careful to avoid touching the RPE cells, causing direct trauma to the RPE cells. In this case, I actually use short-acting gas, SF6, instead of C3F8 because patient is monocular. Fortunately, the macular hole was closed after the second surgery and patient was able to see better. And thank you for watching.